pharmacology students, this is Dr. Sue. Today's lecture is going to be on the CNS or central nervous system drugs, and there are several categories of these. This is competency 8, and if you look on pages 21 through 23 in your syllabus, I'd like you to review those learning objectives. You should be reviewing the function and physiology of the central nervous system, identify some of the common classifications of medications that we use to manage things like insomnia, seizures, psychosis, anxiety, depression, bipolar disorder, epilepsy, Parkinson's, and Alzheimer's. You want to know the major actions and uses for the different classifications of meds. And we look at overall just the major categories of meds we use to treat mental health disorders in our communities. And then you want to identify and discuss some of the more common disorders we just mentioned, looking at common side effects, actions, and therapeutic effects of the medications, and how do we use evidence or evidence-based practice when we work through the nursing process as we're administering these meds. So the lists of meds are, on your pages 22 to 23, and also your content comes from several chapters. I'm not going to read all the numbers to you, but it begins on chapter 18 in McKiston. Also, I would again emphasize that it would be important for you to use your ATI book, 7, 8, 9, 10, and 11, 13 and 16, and they do give you, those are very small, 3 to 4 page chapters, but I would highly recommend the questions at the end of each chapter as well, so that you can practice these types of questions in preparation for your Unit 4 exam, which you'll be taking on week 15 on December 10th. Or the week of the 10th, 11th, 12th, and 13th. All right, so let's get started. So again, we're going to identify and define these diseases that are treated with CNS meds. And I don't think any of these are unfamiliar to you. Okay, let's just mention a few things here. When we talk about things like psychosis and associated depression, bipolar. What do we mean by psychosis in and of itself? Well, that's losing contact with reality, and this can happen. The psychosis can occur with many of the mental health disorders. Also, when we look at a mental health disorder such as schizophrenia, that's a chronic psychological disorder, and that is one of the major categories of psychosis. So within psychosis, you should think of schizophrenia, because we do have specific medications, obviously, that we use for that. A classic one known as lithium, and we'll be talking about that more. First thing is, we'll start with the sedative hypnotics. These are CNS depressants. These meds are used to alter your patient's responses to whatever environmental stimuli might be happening. So they are CNS depressants. They do calm patients. They make them unaware of their environment. They do not affect consciousness, though. Hypnotics will produce drowsiness. The meds can both sedate and cause hypnotic effects. Oftentimes, when we give a larger dose of the same medication, it will result in a patient falling asleep. Now, in the hypnotics type of medications, there are short and long acting. The short acting hypnotics will produce sleep without lingering side effects, and the intermediate acting ones provide action for a longer period of time. Patients still may experience morning drowsiness with these, though, and that hangover feeling. So we want to monitor those and watch for those symptoms. As far as insomnia, medications to help patients get off to sleep. You know, an over-the-counter one that's commonly used in all of the medication combinations that say PM, so like Tylenol PM, Advil PM. The PM is the actual Benadryl, which we talked about before as an antihistamine, but it has a side effect of sleepiness. So patients take this in the form of over-the-counter Tylenol PM in order to get off to sleep. Insomnia is a really chronic and common problem that occurs in approximately 10% of the general population. Also occurs in about 1 in 4 hospitalized patients. In mental health situations, so like in a behavioral health ward where patients are staying, 3 out of 4 will have sleeplessness. So in mental health patients themselves, they have a much higher incidence of insomnia. It occurs more commonly also in women and elderly, and these groups of medications are used to treat this insomnia. So I already mentioned that the first generation antihistamine, or Benadryl, is one of the more common ones that are used, but we also use barbiturates. They had at one time been a large group of medications that were used more frequently, but now there's only about a dozen of them left on the market. Due to some of the interactions and serious side effects and long-term use effects, they've been pretty much narrowed down. Some can be used for seizures, or they can even be used as anesthetic, but we do have a short-acting barbiturate called Seconal that can be ordered for sleep. You don't see this commonly used anymore because of the bad side effect profile. And when they're used, they should only be used for a very short term, less than 10 to 14 days. Another class we talk about for insomnia is the benzodiazepines. And one of the things about benzodiazepines is they're highly addictive. They need to be used for only short term. Unfortunately, we have a lot of patients who have been on chronic benzodiazepines such as Valium, Xanax, Ativan for years and years, and their bodies are addicted to that. It's very difficult to withdraw them. It's very difficult to withdraw them from the benzodiazepine. We really don't want to use those for more than 3 to 4 weeks at a time. Providers are now beginning to use the non-benzodiazepine medications, and the prototype for that is the Zolpidem, which is the Ambien. And it's really still supposed to be used short term, but the reality is that we do see this medication used on a long-term basis for chronic insomnia. Sometimes one of the things that nurses try to do is to encourage patients to look for the root cause of their insomnia. So we try to use other complementary therapies, relaxation therapy, yoga, meditation, different things in the environment like the lighting, the mood, the sound, sometimes the white noise, machines, essential oils, things like that, because it's not really healthy for patients to be on the long-term sedative medications overall. Now, just so you know, in Chapter 18, your sedative hypnotic medications charts are very important in the content there. But then once you get past the discussion about the melatonins and the different sedatives, you're going to see on page 239 that you start into a area that says anesthetics. You need to skip over that. You need to skip over that and move to the next chapter. So the side effects, again, we mentioned for the sedative hypnotics: the drowsiness, dizziness, the hangover, rebound insomnia. Obviously, they can become dependent. They can have a tolerance. Particularly with some of them, benzodiazepines, you literally have to keep increasing the dose in order for them to actually get the same response, which is really not good for anyone. It's not good for your patients. And the nursing considerations are here. I don't think that this is surprising to you, and you want to make sure they're careful about the timing of the medications. They should not be taking these medications and then driving a motor vehicle, for example, because it can slow their response time. It can make them sedated, and it's dangerous. So some of the medications that we use for example, keeping patients calm and reducing anxiety for anesthesia times. Are particularly the midazolam, which is in the benzodiazepine class, known as Versed. It's one of the most commonly used medications to help patients become sedate, but not in an unconscious state. For example, in the GI lab, the gastrointestinal procedures that are done, the scopes as we call them, patients are given the Versed or midazolam IV to help them relax, but they can still respond. They can still change positions for the provider as the procedure is done. Now, the sedative hypnotic that we use is propofol. It looks white in color and it's given intravenously, and that does help. That's something called conscious sedation. We also use it initially when the patients are going to be induced for a general anesthesia. And with this, respiratory therapy has a high risk of respiratory and cardiac depression. So those are the things, of course, that we would monitor closely. Okay, now moving on to anxiety. Anxiolytics, which is anti-anxiety medication. What these actions of these medications are to enhance the action of the GABA receptors in the brain, which are the neurotransmitters that inhibit excitatory stimulation. So anxiety and insomnia are both indicated for these. It's a large class of meds, but not all benzodiazepines are used for anxiety itself. Some tend to be more used for sedative hypnotic effects, and those that are used for anxiety are given in a lower dose: Xanax, Valium, Ativan. Also, clonazepam can be used, and this is a primary use as an anticonvulsant. Barbiturates are not a drug of choice for this, and you're gonna see that a lot of the indications for these are increasing anxiety that needs to be managed, but we do balance it with limiting the amount of time that the dosing and the amount of time that patients are on these meds. So again, side effects are a lot like what we already talked about. If we would give these IM, you want to give these in a large muscle. And one of the key things to think about is here. You might see something about this again. What kinds of things do we avoid? Anything that's stimulant of nature, so nicotine, caffeine. Remember, any kind of foods or beverages that are going to be stimulant, because we're trying to reduce anxiety. Okay? And so these medications also in the elderly patients are known as chemical restraints. They can be construed as that. Older adults are at much higher risk for CNS side effects, which can result in falls and accidents. So we really limit the use of these. And we can't use them as a restraint per se to control a patient's behavior. These are highly regulated, and that you have to document very carefully when we're using these in a clinical setting. All right, so the next medication group we're going to talk about then are the anticonvulsants. The anticonvulsants act on abnormal neurons to decrease excitability and responsiveness to stimuli, and they prevent spread of impulses to normal neurons surrounding the abnormal ones. So seizure activity is caused by the abnormal firing of these neurons. So you need to remember, just for this class, what the general action of anticonvulsants is, and that it works in one of three ways. So some drugs, such as phenytoin, work by binding to the sodium channel. That suppresses sodium, prolongs the channel inactivation, and results in the prevention of that neuron firing. Other drugs, such as valproic acid, will prevent the abnormal firing by suppressing calcium influx. So when the electrical current is generated by calcium ions, so if we have less ions, the less likely it is that that abnormal neuron will fire. And then barbiturates obviously increase the GABA, which inhibits neurotransmission in the brain. So overall, you just need to understand that anticonvulsant therapy prevents the seizures. It does not cure the disorder. For seizure disorders, there really is not a cure, but we can control seizures in about 70 to 80% of patients on an ongoing basis. So some anticonvulsants, most of the main focus of anticonvulsants obviously is to eliminate seizure activity or control it, but also we use them as a secondary for chronic nerve generated pain. So we have to make sure we choose the proper meds. So some of the types of seizures that they treat are the grand mal or the tonic clonic. That's where the full body is moving in a rhythmic motion. Then we can have, it's like a tightening and jerking. These are the most common. They can last about 2 to 4 minutes. The second type of seizure is the absence seizure, where patients will have a brief loss of consciousness for less than 10 seconds. Sometimes you'll just see patients when they have this, they just have a blank stare for a few seconds, and that's how people notice that they're having these. There are also other complex seizures that have repetitive changes, or motor seizures. So a lot of different types of activities that are going on. And the drugs that we use here, again, there are many groups of them. The hydantoins is the phenytoin, and that's the dilantin. This is the drug of choice. In Chapter 19, these medications are defined for you on page 247. 248, the prototype of phenytoin is there, so you should review that. The barbiturates like phenobarbital can be used. That's usually used for short-term and in an acute care setting. Patients can be on carbamazepine, which is Tegretol. Carbamazepine can also be used for certain psychological disorders. I have also seen small doses of this used for restless leg syndrome. So if you see a patient on carbamazepine, it doesn't necessarily mean that they have a seizure disorder. You should ask them about restless leg, because we do sometimes use it for that. Benzodiazepines, certain ones like Valium and clonazepam, are used. Usually we use diazepam or Valium in IV form for something called status epilepticus. So if a patient comes in a grand mal seizure that just doesn't want to end, we give IV Valium. That is the drug of choice. Valproic acid or valproate, along with divalproic sodium, which is Depakote. And again, Depakote is one that's used for bipolar or manic episodes as part of the bipolar disorder. Gabapentin, which is Neurontin, is the most common one that's used as a secondary effect for nerve-generated pain. So when patients have had back problems like spinal stenosis and injuries to their back where they have nerve root impingement, so they have symptoms down into their lower extremities, for example, or in their cervical spine and symptoms of numbness and tingling into their arms, we use gabapentin for that nerve-generated pain. Also, diabetic neuropathy, it can also be used for that. So the side effects, of course, are much like anything that affects your central nervous system. You need to look at every single medication. There are some of them that can become toxic in the blood. So, for example, one of them is dilantin. We do dilantin levels. And we measure that. It's often the drug of choice for the seizure disorders. So patients can have periodic dilantin levels drawn to make sure that they are not becoming toxic of the medication. And one of the things, the common side effects with long-term use of dilantin is something called hyperplasia of the gums. They will get the red, puffy-looking gums. And the patients that are on long-term Dilantin have to be taught to have very meticulous dental care. So that is one of the things that we focus on with that. And this is just a pictorial for you to look at the different anticonvulsant medications. This is the Tegretol we talked about. It's an anticonvulsant also. Okay, and it's for maintenance. It stops the seizures before they start. And this is the benzodiazepine, Klonopin or clonazepam. And this oftentimes helps something called petit mal seizures. Okay. Gabapentin again is the Neurontin that we use both for anticonvulsant and for that neuropathic or nerve generated pain. Some of the nursing considerations then. Here are, of course, monitoring the serum blood levels for those that are measurable in the blood, and you can see it's the valproic acid and the phenytoin or the Dilantin. Okay. So Dilantin, valproic acid both have low margins of safety, so they have a narrow therapeutic index. They both require periodic serum drug levels. And then many of the anticonvulsant drugs have a low margin of safety and require close monitoring and assessment. Phenytoin particularly needs to have CBC drawn because patients can have leukopenia, thrombocytopenia, and agranulocytosis. Any patient who's required to be on long-term seizure drugs, we have to make sure we do a good assessment of the possible drug-drug interactions. We are beginning to use for anticonvulsant a newer medication called Keppra. And Keppra does not require the kind of monitoring that some of the other medications do. It also doesn't require ongoing blood monitoring. Let's see. Obviously, children will be more sensitive to these drugs. They're at risk for more adverse side effects. We're starting to see the use of more modern anticonvulsant medications in these populations. We talked about psychosis already. We mentioned what it is. You can have an acute psychotic episode, or it can be a chronic problem. It's a disordered thought process. There are inappropriate emotional responses associated with it. Patients will be seen as having odd or strange behavior. They can be very hostile. They can have hallucinations. It can be tied to things like autism. They have delusions, and a loss of ability to function. So usually there's more than one thing going on. One of the more common chronic psychotic disorders that is a type of psychosis is schizophrenia. And the typical onset for this is as an adolescent or young adult. And some of the signs and symptoms would be divided into either the the positive or exaggerated symptoms and the negative or depressed symptoms. A lot like bipolar, right? So positive symptoms: exaggeration of normal function, hallucinations, delusions, incoherent speech, agitation, becoming very excitable. Whereas the negative symptoms then will be more chronic and persistent: lack of self-care, social withdrawal, loss of motivation, functional limitations. It's a very difficult diagnosis, schizophrenia. I wouldn't wish it on my worst enemy. It's difficult to treat, and the medications are not easy to take. So we'll talk about antipsychotics. Most of them bind to the D2 receptors. They're dopaminergic, and they block the actions of the dopamines. It is thought that these psychotic symptoms result from an imbalance, of the neurotransmitter dopamine. So that's why the meds try to block the action and reduce the psychosis. The goal of this treatment is to improve the thought processes and behavior. The use of these medications, of course, is primarily for the psychological disorders, but they can also be used as sedation when patients are agitated, or they can be used for movement disorders such as Tourette's, or Huntington's. And Huntington's, of course, is a CNS disorder with involuntary movements, worsening emotional and behavior disturbances related to dementia. Very, very rare. Tourette's, of course, is a neurological disorder that has repetitive motor and verbal tics, and it can be associated with OCD as well, obsessive compulsive behaviors. So antipsychotics come in two main categories, the typical and the atypical. And you'll see more of the atypicals being used, although we do use the phenothiazines and non-phenothiazines. Haloperidol is a hallmark typical antipsychotic medication. And for that, I would encourage you to look at your chapter 19. Let's see here. Get to the point here where... Oop. Oh, I'm sorry. No, we're in chapter 22 for antipsychotics. This jumps around a little bit, but it starts on page 280. And I would like you to review some of the, there is a table that shows some of this dystonia and akasthenia. Haloperidol is on 284, and the medication table 285 and 286. So review those in chapter 22 as you're looking at this content. The atypicals are newer generation antipsychotics. Zyprexa, Risperidol, Abilify are more tolerated. They treat positive and negative symptoms. They can be more effective in treating those negative symptoms, and they have less side effects overall. So, obviously in the autonomic nervous system, they can have enhanced anticholinergic symptoms, so they can be dry, they can have tremor, change in libido, irregularity of the menses, tachycardia, things like that. They can also have something called EPS, extrapyramidal symptoms, which is important because patients will develop this over time. Tardive dyskinesia, pseudo-Parkinson's, like shaking or fine tremors. They can have acute dystonia. And so these are the reasons why we don't like to use the typicals, because they have these extrapyramidal side effects. We see much less of those with the use of the atypicals. Side effects of the atypicals are here. We do worry about orthostatic hypotension and tachycardia with them as well. So one of the biggest issues with these medications obviously is compliance, because as you can see, the side effects are no fun. They have a lot of stigma associated with them. And it's very common for patients to stop their drugs when their symptoms improve, which causes them to keep coming back in for exacerbation of their psychosis. So this is a big problem. Okay, and and you should review some of those extrapyramidal side effects in your textbook, chapter 22. Nursing considerations, of course, would be monitoring their vital signs and symptoms of possible potential side effects. We want to do a lot of patient education. And we want the patients to reach out. We really encourage them to reach out rather than stopping their meds if they're having side effects that they don't want to tolerate. Some of the extrapyramidal side effects might be irreversible. So, we are very careful about how we use these medications. This is really, most of the time, these patients are managed by people who are specializing, even nurses that specialize in mental health. And in children, we're very cautious, and in the elderly as well, we use smaller doses of these medications. Patients do have to have periodic lab work as well, along with readings of their white blood cell count. All right. So, the next common mental health disorder, that's the most common one treated, overall in your population is depression. And the common theory is that this is related to a deficiency in serotonin. It's estimated that 10 to 20% of the population suffers from depression, but only about a third of those are treated. It's a stigma being treated for depression. It's much less than it used to be, but it still exists. There are also improved antidepressant medications, so patients are more likely to be compliant with treatment. So now, it's really not sure exactly why it occurs. There is no definitive answer. But the theory, common scientific theory, is that there's insufficient amounts of these brain neurotransmitters, particularly serotonin and norepinephrine, and that this is what leads to depression. So the drugs that are most effective to treat this are medications that increase these neurotransmitters. Some of the social and environmental factors in the patient's existence is also something that can occur. So patients can have something called situational depression, and that's most common when they've experienced major losses, loss of a loved one, or they're diagnosed with a serious disease. So we have three major classes of depression. We have reactive, we have major depression, and then we have bipolar affective disorder, which is more related to mood swings where the patients become highly manic and then swing down to be severely depressed. So the actions of antidepressants are to increase that availability of that norepinephrine and serotonin. We use that for depression, chronic pain, and also obsessive compulsive disorder. So there are four groups of medications. We have tricyclic antidepressants. Amitriptyline is a common one of those. And we're going to be looking at these medications in Chapter 23. Okay, Chapter 23 starts on page 294, and on 295 we're talking about the tricyclic antidepressants. They are to treat major depression. They are effective. They have many side effects. They're less expensive than SSRIs. And amitriptyline is a common one. By the way, amitriptyline in low doses can also be very effective for treating nerve-generated pain as a secondary use. It blocks the reuptake of serotonin and norepinephrine. And these, as a class, as a major class of these meds, it is important to know that they have a very long half-life. So we don't see clinical responses to these medications. We always tell patients to give it 30 days. They should start seeing a change in their affect within 2 weeks, but it does take 30 days in order for us to get a therapeutic blood level of these meds. So here's the tricyclics. You can review that on your own. The next class is the one that's the very common, most common of all. It blocks the uptake of serotonin, selective serotonin reuptake inhibitors. We treat major depression with this, and we also use some of these. Some of them are better than others with anxiety disorders. Fluoxetine is a common antidepressant. SSRI, Prozac, sertraline, which is Zoloft, citalopram, which is Celexa, escitalopram, which is Lexapro. And these are the SSRIs. I'm not going to go through this in detail. You can look at this for yourself and copy down some of the information. Okay, some of the atypical medications that we have a group that's, we actually know that that's a norepinephrine and serotonin reuptake inhibitor, Wellbutrin or bupropion. Bupropion is also in the form of something called Zyban, another trade name which we use for suppressing the desire to smoke cigarettes. So it's used as an adjunct, as a secondary use for smoking cessation. Now, another class of medications called MAO inhibitors is rarely used. There's one called isocarboxazid or Marplan. The problem is that they can be as effective as tricyclics, but because of the adverse reactions, they can have hypertensive crisis. They are used in less than 1% of cases. I've actually never used MAO inhibitors because they interact with every other medications that patients are taking. So it's just an FYI. I don't think we're going to ask you questions about MAO inhibitors. And then, of course, we do have some herbals, St. John's wort and ginkgo biloba, that are supposed to enhance mood. But the problem is some of these can also be interacting with your prescribed medications. So we use them with caution, and there's really no regulation of these herbal products. This talks about MAO inhibitors. I really don't want you to focus on that, though. You'll never see them in practice. So I'm going to skip past that. So here we go. So you have the tricyclics, the SSRIs, the atypical, which is your Wellbutrin, and then your MAOs. And the side effects are all listed there. I don't think any of this is that unusual or surprising to you. And when we're assessing for depressants, of course, SIGI caps, so sleep disturbances, interest decreased, guilty feelings, energy decreased, concentration is decreased, the appetite can wax and wane, lowered psychomotor function, suicidal ideations. This is just a way to assess for depression. Some of the nursing considerations, obviously, we always get a baseline assessment. Always, always, always ask about suicidal tendencies. Have you ever thought about taking your own life? Have you ever come up with a plan? Have you ever decided that you don't want to be here? Those kinds of things. And we have to document that. It's really important for us as healthcare providers to be on the front lines of suicide prevention. And I don't know if any of you, as you go through this program, you'll get a chance to go to a presentation by Beth Doria on suicide prevention and how we can all intervene and help patients so that this doesn't, to reduce the incidence of this, because it is very visible. It's very frequent that it's occurring. Some of the high-risk populations are the adolescent population, the young adult population, the veteran population. So we want to make sure that we are using all the tools in our tool chest to try to minimize the risk of suicide. Okay? And patient teaching, along with all the other things we talked about, is still an important fact. All right, now we're going to move on to lithium. Lithium is the hallmark treatment for bipolar disease. Now, lithium is a very potent medication, and it does come with a whole laundry list of concerns when we're having patients take this. So when a patient has the opposite of depressed symptoms, they have something called mania. And in patients with bipolar disease, they experience periods of depression followed by a very high manic episode. We're not exactly sure, the science is not exactly sure why, but they think it's related to overstimulation of the neurons in the brain. And the mainstay treatment for bipolar disorder from this point on has been lithium, though now we're starting to see some newer drugs on the market that we're using, Seroquel, Abilify, and Zyprexa, which have much less side effects than the lithium. We're going to briefly cover lithium and its many side effects for this competency. It's a dangerous drug with potential for CNS, renal, and pulmonary problems. It is used because it's consistently effective in controlling mania. So it's very selective as to who we put on this medication. It functions in several ways. It inhibits release of neurotransmitters norepinephrine and dopamine, but not serotonin. And it'll increase receptor sensitivity to serotonin to selectively modulate the responsiveness of the hyperactive neurons that contribute to the manic state. And we're not really sure why, but it's very good at controlling mania, but allows the patient to function relatively normally. Okay, it's an unsafe drug with many side effects. We've listed only a few here, those that would be the most common ones that you would see. Patients usually start out with biweekly serum drug levels, and as the levels stabilize, then they can go to monthly lab work. But there are many drug-drug interactions, so we have to closely assess the patient's drug regime. The nursing implications would be similar to those of antidepressants, and patient education is key. They have a risk for hyponatremia, so we increase fluids and sodium as needed to decrease that risk of toxicity. The patients will get dry mouth, so we encourage them to do things like sucking on lozenges, drinking lots of water so that they prevent injury, good oral hygiene. This is not an approved drug for children, should never be given to children, and older adults would take these medications very rarely, and they would need to have a close assessment of all of their labs, including renal function. The next condition we're going to talk briefly about is Parkinson's. Parkinson's disease, is a chronic neurologic disorder that's progressive, and it affects that EPS or extrapyramidal tract, so controlling balance, locomotion, posture. I'm sure you're very aware, you've seen the celebrity Michael Fox with his Parkinson's journey, and you see him, Michael J. Fox, he's doing things in Congress to talk to the Congress, members of Congress about getting better treatment for Parkinson's, and he's done just a real lot of work to try to bring this unfortunate disorder into the mainstream so that people are thinking about it. But the key features are that patients will become very rigid, and this will increase this rigidity of their muscles as they try to move. They have bradykinesia, and they will have tremoring. So you'll see that these patients will lack facial expressions. They'll have something called pill rolling, where they roll their fingers and their digits. Involuntary tremors. They'll have a shuffling gait, and they'll have a real loose. That's what they mean. It says loss arm swing. They'll have to swing their arms as if the arms are propelling them forward. That contributes to that shuffling gait. So the three classic symptoms will be that there's rigidity with movement, the bradykinesia, and the tremors, but you'll become very familiar with the way if you're ever around a patient that has significant Parkinsonism. The medications are the dopaminergics, the most common type of meds used, and they're the only ones that you need to really know for this competency. Okay, they basically they convert to dopamine once they're in the system, which their body tends to need more. Levodopa, this is the most effective drug. Only 1% reaches the brain, so they need very high doses. And then what we do is we add something called carbidopa, which prevents metabolism of the levodopa before it reaches the brain. So we have a ratio of 1 carbidopa to 10 levodopa in these pills, and the combo med is called Cinemet. So more dopamine will reach the brain. We can dose it daily. There are smaller overall doses of levodopa in the Cinemet. Some of the disadvantages are that there can be more side effects due to the fact that there's more availability of the med. Anticholinergics, of course, can also treat this condition, dopamine agonists, MAO-B inhibitors, and then we have another one that's called a COMT inhibitor. We're not going to be quizzing you on those other categories. For the purposes of Parkinson's, we want you to know the levodopa, carbidopa. Side effects are as follows. I'm not going to go into a lot of detail about this. You can review this in your text. And the nursing implications, of course, would be checking the medication regimen, giving it with food. It can cause nausea and vomiting if patients can have that. Monitoring your vital signs because they can become hypotensive. And we want to make sure we instruct patients for safety related to dizziness. Do not abruptly stop because patients can have rebound side effects. We want to make sure that they're monitoring for worsening of their Parkinson's symptoms, of course. All right. All right, the last category that we talk about here in this area would be your Alzheimer's. And of course, we know that Alzheimer's itself is an incurable dementia. Its onset is at ages 45 to 65. There is no cure. There are 40. Um, oops, sorry. Um, the, the chronic progressive disorder involves the neuron degeneration in the cortex of the brain, and this leads to impaired memory and loss of ability to perform normal activities of daily living. There are many theories related to the degeneration of neurons, loss of neurotransmitters, and something called plaque formation in the brain. And this is a progressive process of confusion that will lead to more severe signs and symptoms and a loss of ability to care for themselves. And this just shows what the differences are in the way that the actual neurons look. You can see it's a degeneration of those structures in the brain. Okay, oops. In Alzheimer's, of course, we know that it's the acetylcholinesterase inhibitors that are the drugs that are used. One of the key things to make sure we tell patients and their families is that these are not going to reverse the symptoms. The goal of donepezil or memantine, which are Aricept or Namenda, are to hold the disease in a state for a longer period of time. So wherever you capture that disease progression, we hope to slow that down and hold off the progression of it. That's what these medications are meant to do. They elevate the acetylcholine concentration to improve memory. This wording is not right on this slide. So we want to lower memory loss, slow the disease progression. Short-lasting effects, unfortunately, they are not a cure. They slow the process better for some than others. There's no guarantee, basically, but it's worth it. Families will say it's worth it. Now, some of these medications can cause GI side effects. With personal experience, donepezil tends to cause diarrhea more so than memantine for patients, and oftentimes they can't tolerate the diarrhea. These are older patients typically. They're already concerned about their bowel and bladder habits, so it makes those symptoms worse. They can have dizziness, headache. They can have a change in their mood related to these meds as well. Some of the nursing considerations, obviously, support to the family and the patient. That the patient is safe. We have to use safety measures. That they are able to remain as active as possible, maximize their autonomy. We get baselines, of course, memory baselines, labs, vital signs, self-care. There's a lot of interaction in this situation with case management and support groups so that patients and families are getting what they need. And we monitor the effectiveness on an ongoing basis. These patients are followed up frequently, usually at 3-month intervals. And that's really all I have for competency number 8. Again, I would encourage you to read through all your chapters that are listed in the book. You do have a quiz that combines some questions about this and about analgesia and pain management, which is going to be competency 10. You have until December 8th to complete that quiz. And I hope you all have a good couple of weeks. We will be in touch.